So I'm going to spend just the next few minutes in a very sketchy way, because I don't want to get into too many of the details, because this is going to be discussed by people who I do see in the audience. And that is, what is the role of NIH and why do we get involved in this? This slide is really an evergreen slide. I show it no matter what disease we're dealing with. What prompts us to use the talents of our investigators throughout the country and the world is that for us, we do research in immunology, microbiology, and infectious diseases for all of the areas you see there. And the two things that drive us are the public health need and the scientific opportunities. And where there are not scientific opportunities, when you have a brand new disease, you create the scientific opportunities. So very quickly, let's take a look at the public health need. We don't need to spend a lot of time on that. We really do know what the need is. A historic pandemic, the likes of which we have not seen in well over 100 years. So part one of the two pillars that drive us is clearly accounted for. Then you talk about the scientific opportunities. If you look at the results of what we have now as a result of science, this is just the vaccines that have now been utilized predominantly in the United States, but also worldwide. If you look at the platform technology on the left, the immunogen design with people like Barney Graham, who is actually in the audience here, that takes the fundamental science that has been invested for decades. And I think what people don't understand is that when you get started on a project, you don't start the day you get your first case of HIV or your first case of COVID. It's literally decades of investment. And that's the reason why we've had such success with the vaccines that was outlined by Ashish and by Alondra. And you know the numbers, Ashish mentioned them. We've already averted well over 2 million deaths, approximately $1 trillion in healthcare costs, and tens of millions of infections, as well as close to 20 million hospitalizations. That's the good news. What's the sobering news? The sobering news is why we're here today, because our job is not done. Because over the past 20 years, there have been 3 coronavirus outbreaks: SARS, MERS, and now COVID-19. Since September of 2020, this virus has continued to prove more than a formidable foe, with variants of concerns emerging, each with a bit of enhanced transmissibility. How do we know that? It keeps bumping off the prior variant, as we're starting to see now with the highly transmissible BA.5. Now, innovative approaches are clearly needed to induce broad and durable protection against coronaviruses known and unknown, hence what we're talking about, next generation. But there are 2 pillars of the next generation that we're all interested, concerned with, and pushing for. One is a pan-coronavirus vaccine that has both breadth and durability. That's important. And next, mucosal vaccine. So let's take a look at the pan-coronavirus vaccine. In December of 2021, my colleagues and I wrote in the New England Journal of Medicine back then that there was an urgent need for a universal coronavirus vaccine. Now, here's where we got to be a little careful, because if you look at coronaviruses in general, that is very aspirational. So what are we doing? We're going step by step. And you do that by looking at the coronavirus phylogenetic tree, as you see here. Now, the 4 coronaviruses that go from the alpha and then in the lower part of the beta are the common cold coronaviruses. And the 3 that you see within the beta are the ones we've had experience with since 2002, namely SARS-CoV-1, MERS, and SARS-CoV-2. Now, another subtle concept that I want to make sure we discuss during this summit is that when you're talking about the ability to protect, it's very interesting, because what we were learning and are learning now about the common cold coronavirus may show some insight. A paper that came out literally a couple of days ago from one of our grantees, Alex Sette, showed that it's very interesting. Namely, you could have immunological memory from a virus that's different than the virus you're dealing now, that doesn't protect against infection, but protects against severe disease. So now the pillars are dividing. You could say you may have protection against infection or not versus protection against severe disease. And we have to take that into consideration in our design. So what about a pan? Let's start off simple. Instead of the whole phylogenetic tree, let's look at pan SARS-CoV-2. We have multiple variants of concern that we need to deal with. And right now, it's even getting more complicated, because if you look at the SARS-CoV-2 family tree, we now have sublineages of sublineages, each of which has a transmission advantage for a number of reasons. One, it eludes protection from infection and prior vaccination, and vaccine-induced immunity and infection-induced immunity wanes. So you have two things going against us, which is the reason why when you look at what we can do, we've got to look at breadth and we've got to look at durability. That's a scientific challenge. That's not an implementation challenge right now. And that's the reason why you have to have science together with risk type of implementation, which was actually the formula for the success that we had originally when we were dealing at a time when we had no idea we would have these variants. That has changed, and we've got to be flexible enough to move with that change. So let's go to the next step. The pan-Sebecoviruses, namely one that would not only be good against the variants of SARS-CoV-2, but others might emerge. And the reason it's important is if you look right north of SARS-CoV-2, you see a number of the bat coronaviruses, which the most recent studies now about how you get evolution from a bat to an intermediate host to the human, it's very important for us to understand how we can get immunity that's vaccine-induced against this. So what is the NIH doing? Let's talk a little bit about it. Again, getting back to what I said, our job is not to develop a vaccine. We are not a vaccine production company. Our job is to facilitate by providing our scientists, brilliant scientists, many of whom are in this room right now, with the capability and the support to pursue the scientific leads, but also, and this is important, and I'm sure we'll hear about it later in the day, to remove any obstacles that are in the way of a very expeditious pursuit of your scientific goals. And we know there's a lot of them. There's enough animals. Is there enough this? There is enough that. Those are the kind of things that we can do. So since the start of the COVID-19 pandemic, NIAID has spent about $3.5 billion on coronavirus research, about $1.5 billion on vaccine research. And recently, we awarded about $43 million over 3 to 4 years at academic institutions, some of which are represented here, for the development of broadly protective coronavirus vaccines. And we anticipate additional awards within weeks. Now, to let the public know, to avoid confusion, when we talk about the development of a vaccine, I want to reemphasize, we can't do it without industry. So industrial partnership from the beginning and de-risking, as we have done rather successfully, is critically important. So when we talk about vaccines that are out there, almost invariable, I can't think of any that don't have fundamental basic science supported by the NIH with their fingerprints on that. We didn't develop it. We're not a drug company, but the fingerprints are there. And here are just some of the examples of broadly protective vaccine candidates that receive NIAID support. You're going to hear from many of these people. Some of them are already in various stages of development. Now, one concept that I think is important for people to understand, the key approach to broadly protective with breath is you either take a common element of a virus and you then vaccinate someone that covers all of the subgroups. That's what's trying to be done with influenza. I'm sure many of you are aware of the stem approach because that's the least part of the virus that mutates. But another really exciting is a different approach that may get by without mRNA or be part of an mRNA, and that is a mosaic approach in which you take multiple parts of the virus, multiple respect the binding domains of different viruses, and you put it on a nanoparticle. And in fact, a paper just came out in Science 4 days ago from Pam Bjorkman and colleagues that did just that. And those are the kind of things that are the exciting science. This is just a few of the publications. I mean, I would have to just give you 5 slides to show them all. I've just taken some representative ones. So how are we going to enhance that? We have now awarded PO1s, or program project grants, to design and development of pan-beta coronavirus vaccines. And you see here, it's Duke, Wisconsin, Rockefeller, Brigham, and many of the people who we're going to be talking about the basic science are involved in this. And then there's the mucosal vaccine. And again, the importance of mucosal vaccines. So I try to make this slide. This is my 5th version of the slide. I didn't want to make it too simple that you'll say, duh, and I didn't want to make it too complicated that the general audience wouldn't appreciate it. When you give an intramuscular or an intradermal vaccine, you get good systemic protection. You can get high levels of antibody that will spill over into the upper mucosal area, and for a period of time will protect you. But to ask to have astronomically high levels of antibodies that spill over is a non-starter, because if we did that, everybody would be hypergamma-globulinic with every stimulus you get. So you get good protection systemically, as shown with the protection against the lung, among other organs, depending on the virus. When you have a mucosal, and in this case intranasal, what you do is you stimulate at the local level, so that the goal of that is not only to protect against disease, but to protect against acquisition, and by acquisition, transmission. And that's really the holy grail of the 2 pillars: durability, breadth, acquisition, transmission. That's what we're talking about today. So the transformational promise of this, faster immunity recall, so that if you get exposed to the virus, you hit it right where it enters. Infection and transmission blocking, and needle-free delivery. And again, no need to go over all of these. These are just some of the candidates that are in various stages: basic, preclinical, clinical. One example of something that's very close to what we're doing right on campus at the NIH is that Jeffrey Taubenberger and his colleagues are using now an intranasal mist of inactivated whole virus vaccine, which is aimed at getting broad protection against both human and beta coronaviruses. Okay, so what are the challenges ahead as we come to the close of this discussion on my part? Looking forward to the follow-ups. 1, we need better validated animal models and methods to sample and quantify mucosal immune response. We lack really good correlates of protection. The potential delivery device considerations we need to expand. The theoretical safety concerns of some platforms, sticking a receptor binding domain in someone's nose, there could be a safety issue there. Unknown clinical trial designs and endpoints, regulatory pathways that need to be clarified, requirement, very hard and very important requirement for industrial partners. So what are the lessons we've learned from COVID-19 that we must apply looking forward? Consistent investments in basic science that leads to highly effective vaccine platforms and immunogens. We can't do concept development and early concept proving without fundamental basic research. We need to continue leveraging the resources that we have. One of the successes of the COVID trials was we leveraged the clinical trial network that we built over decades for HIV. We need to do that with these vaccines. Early partnership with industry and biotech in advanced development and manufacturing prior to the proof of efficacy, referred to as at risk. That led to unprecedented time frame for the availability of safe and effective vaccines. And finally, ending with something we all know. The cost of major investment of research pales in comparison to the cost of a pandemic. Thank you.